Every year, thousands of infants are misdiagnosed with colic, reflux, or standard starter reflex when they are actually suffering from infantile spasms like this baby. By the time they reach a specialist, critical windows for development have closed. Today, this lecture is designed to give you the exact diagnostic tools and clinical practice needed to differentiate benign infant behaviors from West syndrome, ensuring that this patients get straight to a pediatric neurologist just without a delay. So let us see about infantile spasms. This baby is having infantile spasm. Infantile spasm affects roughly 1 in 2,000 to 4,000 live births. The peak onset is 3 to 7 months of age. Infantile spasms and West syndromes are frequently used interchangeably. However, strictly speaking, infantile spasms refer to the specific types of seizure, just brief, sudden, jerking muscle contraction, while West syndrome refers to the overall medical syndrome defined by a specific triad of symptoms. So the West syndrome triad include characteristic epileptic spasms, interictal EEG patterns of hyperarrhythmia, just a chaotic high voltage, and developmental arrest or regression. So, to receive a traditional clinical diagnosis of West syndrome, a child must exhibit three specific criteria. The first, infantile spasm, which is sudden, repetitive, subtle movements like head dropping, arm raising, or body stiffening. The other criteria is hyperarrhythmia, which is a highly disorganized, chaotic, and high amplitude electrical pattern visible on EEG. And the third is developmental regression, which is the loss of previously acquired developmental milestones or psychomotor stagnation. As you have seen, the clinical presentation or sign include sudden brief contraction, just 1 to 2 seconds occurring in clusters, and also flexor, extensor, or mixed combination. Just flexor include head drops, body bends forward, it's called jackknifing. The extensor up is called arms and legs pushing outward, and also mixed both flexor and extensor combination of flexor and extensor movement. Associated signs include loss of milestone, loss of smiling, rolling over, eye contact, and also sometimes it's often misdiagnosed initially as reflex or colic. Regarding etiology, 60–70% of cases are symptomatic. It's due to either tuberous sclerosis complex, hypoxic ischemic encephalopathy, brain malformation or stroke, or metabolic or genetic disorder. And the rest is idiopathic. Development was normal, prior to onset with no clear structural cause found. Diagnostic evaluations include EEG. EEG confirms diagnosis through the pathognomic chaotic hyperthymic pattern. And neuroimaging is important to prioritize high-yield brain MRI alongside supplementary laboratory panels. The Stop Acronomies portal highlights caregivers' early recognition awareness steps. See, take video, only act fast, progress to specialists. So the gold standard investigation is EEG. Interictal EEG pattern shows high voltage, chaotic, disorganized hyperarrhythmia. And the brain MRI is used to check for structural lesion. Also genetic and metabolic screening panels. Regarding management, our goal is immediate cessation of spasms and the normalization of EEG. First line is medical therapies, specifically hormone therapy, adrenocorticotropic hormone or high-dose oral prednisolone. And vigabatrin is preferred first-line choice if the underlying cause is tuberous sclerosis complex. The prognosis is strongly tied to how early treatment started and the underlying root causes addressed. This is a summary of infantile spasm. Thank you for watching.